we will discuss about ECMO neuromonitoring. This is one of the very important topics. I have no financial relationships with ECMO related companies as per my disclosure. The objectives of this talk are why it is important to monitor the neurological status on ECMO patients, where are the difficulties in assessing, and how do we do it clinically as well as using wearing various devices. We'll also talk about the imaging and other modalities. Brain is the most important organ, as you know. The key factor in accepting a patient for placement on ECMO is the neurological status, really, making sure that they haven't got any intracerebral bleed or intraventricular bleed, which could be made worse on heparinization. Decides the course of ECMO too. The ECMO risk factors in the brain are if the patient has already suffered ischemia or hypoxia, hypotension, etc. This is the most important factor which can predispose to neurological events. Systemic heparinization can add to the injury, but it is not the primary factor as such. Impairment of cerebral autoregulation is being looked at more and more often. Microemboli and effect of carotid ligation reconstruction also could be contributing factors. The difficulty in assessment of the neurological integrity of a patient could be due to effect of sedatives and paralytic in these critically ill patients. Need for readily available dynamic tests is also felt. Transporting patient on ECMO with cannulae for doing a CT scan is not very easy. One needs to go through that before in the form of trials in their own hospitals. Physiological closure of windows such as anterior fontanelle in infancy adds to the difficulties in monitoring non-invasive neurological monitoring using ultrasound in infants. Despite the risk of over or under cerebral perfusion, we notice ECMO protocols are based on systemic factors rather than brain-specific metrics, leaving the brain at risk of injury. So some of the CNS complications are bleeding, ischemia, seizure activity, hemorrhage, stroke, and brain death. The ELSO registry data of April 2022 in adult patients, adult respiratory group, it shows the incidence of these various parameters such as clinical seizures, CNS diffuse ischemia, CNS hemorrhage, ultrasound or CT diagnosed, intraventricular CNS hemorrhage, CT or MRI diagnosed, only CT while on ECMO, MRI is after decannulation. Neurosurgical intervention performed, etc. And the percentage of patients survived in that as well. So one has to be really careful for avoiding these sort of neurological injuries to the extent possible. Similarly, these are the numbers here in pediatric respiratory group. Again, the incidence, number survived, and percentage survived. The numbers are increasing over a period of time. The percentage reported is around 1.7% of late with 45% survival. The numbers are becoming better and better with time. This paper by Irfan et al. Very nicely describes about detection of brain injury using multimodal invasive neuromonitoring in adults undergoing ECMO. So we will talk about these different monitors and devices in the next few slides. The phases of the neuromonitoring are pre-ECMO or during ECMO, such as seizure, stroke, cerebral ischemia, or hemorrhage, and post-ECMO by CT, MRI, or neuropsychological evaluation. Clinical monitoring. It is essential to monitor daily and frequently the assessment of the neurological status in the form of evaluation of GCS, pupils, mobility, neurodeficits, seizures, and using adjust as well. Pupils are one of the very important signs for us to understand how the underlying brain might be functioning, but it is not the ultimate. Changes in the size, equality, and reactivity of the pupils has been noticed. Dynamic pupillometry provides several objective biomarkers also. Unreactive pupils can be caused by by an expanding mass such as blood clot, exerting pressure on the oculomotor nerve. Unequal pupils are of more significance than bilaterally dilated pupils. Check if there's any pre-existing factors such as cataracts, pre-existing eye surgical issues that can cause pupillary dilatation or constriction. New onset changes are important as a screening test, and damage anywhere along its route can result in abnormal, static, or dynamic pupillary irresponsibility. So this is a picture showing about the pathway of the light reflex. This is the pupillary which exactly measures the size of the pupils and tells about the difference between the two. Electroencephalography, all of us are aware, it measures the cortical activity through a series of electrodes attached to the patient's scalp compared to the so it gives us an overview about the neural compartment of the brain compared to the vascular compartment. Alpha to delta ratios called ADR can be calculated from the alpha and delta waves. Patients with the neurological injuries have also been shown to have a lower ADR value compared to those without any significant injury. So here you can see the neurological monitoring in the form of the EEG recordings. This is another uh, useful device, that is cerebral function monitoring, CFM or CFAM. So it is used mostly in neonates and children. It measures the underlying brain activity under the electrodes. There are not many electrodes in this. There are just 8 electrodes, usually 8 electrodes for cerebral function monitoring compared to multiple electrodes in case of electroencephalography or EEG. So here is a seizure pattern, how it looks like, and anyone can pick up if a patient is having seizure activity. This can be further analyzed by means of EEG, and if there is any structural problem, ultrasonogram and CT scan can tell us much more. So this is more like a screening tool. Here is a picture of CFAM, how it looks like when there is a very minimal electrical activity, uh, just restrained to 1 to 2 microvolts on this compared to the normal picture of up to 25 to 50 or even between 10 to 50 in a very sedated patient. But in this level of 1 to 2 is very minimal, suggestive of brain death or something to be evaluated in the form of a major clot like that. So moving on further, ultrasound in neonates is a very useful device. It allows a detailed and comprehensive examination of the brain parenchyma. That's how it is useful for us. It is a non-invasive methodology, easy to access, low cost, portable, and lack of ionizing radiations as well. In studies, cerebral ultrasonography has been proven to be very useful marker in diagnosing in intraventricular bleeds more often. So be aware of the choroid plexus. As it also looks dense in the interpretation, it has to be differentiated from a bleed. Isolated subependymal hemorrhages, they don't matter. If the IVH intraventricular hemorrhage is more than grade 2, then one needs to worry about placing a patient on ECMO. Daily sonograms are recommended. So going for the cranial ultrasound picture, this is how it looks like. Auditory brainstem responses are also one of the useful tools. It provides information on the subcortical health. By measuring the latency of the specific peaks in respective and responsive signal, injury to specific regions of the auditory pathway, such as brainstem, can be determined by this. Diffuse correlation spectrometry has been useful as well in studies where it is helpful. DCS, as it is simplified only known as, it uses interaction between the light and moving scatterers, those are the RBCs, in the cortical microvasculature to obtain blood flow index called as BFI as a surrogate of cerebral blood flow. Transcranial Doppler we have been using in our ICUs as well, and this is very helpful in measuring the cerebral blood flow velocity of the deep cerebral arteries. Cerebral blood flow velocity from transcranial Doppler and blood flow index from diffuse cerebral spectrometry have been shown to be having good correlation. Near infrared spectroscopy is another useful device which has been coming off in the last decade. It is simply called as NIRS. It is a reflection of the global brain tissue oxygenation. We tend to measure oxygenation over the brain as well as over the region of the kidneys as a somatic index of oxygenation, and we compare how it is done between the two. Here, photons are injected into the overlying skin and they scatter inside the scalp, brain, and brain tissue. So, a fraction of these photons they are reflected back, and this reflectance exits the skin and is picked up by the two light-sensitive photo diodes. So, we read this number and we can compare it with the somatic saturation versus cerebral saturation levels. So this is a very useful and dynamic marker for us to measure the cerebral saturations. Here you can see the penetration of the photons into the brain, and these are the examples of the numbers, how they look like. If they are very high saturation levels over the brain, that is also not very helpful as an index of as an index. The reason for that being there is a lot of oxygenation available in the tissues, but the brain is not picking up. So there must be some sort of problem. It could be temporary problem also, such as at the level of the mitochondrial utilization of the oxygen, etc. So the high numbers as well as the low numbers, they are significant, but they tell that something could be wrong. Ideally, there should be 70% absorption of this oxygenation levels and the differences between the somatic saturation and the cerebral saturations. Unlike pulse oximetry, NIRS doesn't rely on the pulse pressure, and it can read at extremely low values as well and not cut off at 35%. Additionally, like SvO2, it is a measure of the regional oxygen perforation, saturation, sorry. And there are growing data in the use of near-infrared spectroscopy. There are papers available in neonatal adult population as well, showing the importance. CT scans and ECMO are very useful. During ECMO and magnetic resonance imaging, after decannulation, they can localize various injuries such as stroke and hemorrhage. Non-hemorrhagic and structural lesions can be noticed as well. Ultrasound has a very good correlation to CT scan findings, but it involves preparation, personnel planning, and execution. So the pictorial demonstration of how it looks like when there is a hemorrhagic stroke or post evacuation. Seizures and ECMO, they tend to be around 4 to 6%, and due to thromboembolical bleeding events, it could happen. The management is important like any other patient. Look for the underlying cause. What is causing the seizures? Do EEG, CFAM, continuous monitoring might be helpful. Stroke and ECMO could be detected by the gadgets we have got these days. And the common causes could be thromboembolic events, rapid decrease in the PaCO2, hemodynamic instability or shock. Management is by monitoring with the Doppler uh, sonography or NIRS monitoring or hemodynamics as well. Optimal management can be done these days with the neuroradiologist intervention as well or neurosurgical intervention if there is any chance for them to intervene in those cases. So the management is by using supplemental oxygen, cardiac monitoring for arrhythmias, address the issue, keep the blood glucose levels normal, pneumatic compression devices, early mobilization, mechanical intravascular or neurosurgical intervention for thrombectomy in select cases as per multidisciplinary team meeting decisions. Suggested measures in selective cases could be mechanical thrombectomy if possible within 6 hours, But these days, neuro interventionalists have been increasingly using imaging rather than the time to determine the candidacy for intervention. Hemorrhage and ECMO is possible. Monitor and study the coagulation parameters. Intracerebral hemorrhage and intracranial bleeding has got a mortality of 80 to 90%. This is how it can look like in neonates. There is increasing um, emphasis being placed on the study of cerebral autoregulation in patients on ECMO. One of my colleagues, Dr. Um, Lakshmi Raman, is one of the principal investigators in studying cerebral autoregulation on ECMO. Neurological complications are coming down in recent years. This could be because of better management or better diagnostic facilities. Sometimes it could be underestimation due to non-reporting as well. But most important is these patients need neurodevelopmental clinics, follow-up by neurologists, psychologists, and required neurosurgeons and neuroradiologists, etc. You need to be. Rehabilitation, neurorehabilitation is needed. Relevant scans have to be done as well. So the follow-up is by means of scans. If the anterior is patent, ultrasound scans are helpful. If it is closed, CT scans or MRI scans are also quite useful for identifying the infarcts, diffuse edema and atrophy, and MRI gives much more detail. So the take-home message is neurological monitoring in ECMO is essential at all age groups. Clinical as well as supportive tools are helpful for us for neuro monitoring. Transport for CT scan involves operational challenges. Preparation is the key. Cerebral autoregulation is being evaluated, and we will come to know much more about how to manage the integrity of the brain during ECMO with these studies. Follow-up is mandatory in these patients. I'm very happy to answer if there are any questions. Thank you very much for patient listening.